for having me. I'm very honored to be here, but also that was a very generous introduction. So thank you, Jose. I'm going to share today with you guys some of that work that he was just mentioning here. Let me pull up my slides. So I'm going to share some work about the stages of implementation completion. And what I'm going to do is I'm going to start off, for those of you who may have heard me speak before, the first probably 10 slides or so might look familiar to you, because what I'm going to do is I'm going to provide a little bit of background to why it is that we are doing the project that we currently are doing, and kind of explaining to you around the SIG itself and the outcomes that we have found, and then how that spawned the current project. And then I'll share with you where we are in the current project right now. So to begin with, of course, let me just get this going. I want to thank my funders. So I am primarily funded by NIDA myself. The beginning of this work was originally funded by NIMH through an NIMH implementation trial where the SIG was first developed. However, the resources to do that was developed from NIDA. I have the SIG team, and so my SIG team, this is who's on our current project. It is definitely an entire team effort. Over the years, there have been many others. I should probably add them to the slide, because over the years, we've had great consultants and great analysts who have helped us get to the point we are today. All right, so to begin with, Fidelity. I think everybody on this call, all of you guys, of course, involved with the CTN, are very familiar with what it takes to develop an intervention and to understand what evidence-based means. But just briefly, so that we're all on the same page, when we think about Fidelity, typically, we think about it in terms of an intervention Fidelity. And what we mean by that is we want to have adherence to those key treatment outcomes or components, and that we want to deliver those components with competence. And when we do that, we say that we have treatment integrity, and we can hopefully assure that that treatment is being delivered the way that we intend for it to be delivered in order to achieve those positive clinical outcomes. In order to do that, we need to understand what our key components are. So sort of those underlying mechanisms are the building blocks for what makes that intervention work. And so I know a lot of times we talk about adaptation, things like that with the intervention. As long as we are really holding true to those core components and we are delivering the sort of the secret sauce to that intervention, what is it that makes that intervention, then when we make adjustments to that, we aren't modifying what it takes in terms of fidelity for that particular intervention. So similarly, I'd like to take that same approach and think about it when it comes to implementation. So oftentimes when we think of implementation fidelity, folks think about a single aspect of implementation. So they might think about coaching, the coaching process, or remote facilitation that might take place, and feel that that is implementation or helping with implementation fidelity. And it is helping with an aspect of the implementation process. And so, but again, taking that same idea, I'd like to think about the idea of then how do we, in fact, perform implementation activities with both adherence and quality. And now our goal, of course, is to achieve positive implementation outcomes. So to do that, taking this parallel process through, we then need to understand what are those underlying mechanisms for the implementation process. So what is it that makes the implementation work? So I follow, when I think about the implementation process, I like to follow Greg Aaron's and colleagues' work on EPIS, which stands for Exploration, Preparation, Implementation, Sustainment. I'm sure you guys are very familiar with this model. This is actually a much older version or sort of picture of what the EPIS model looked like. And I realize it's fuzzy and you can't see all the outer and inner context variables that go into each of these 4 phases. But the point that I wanted to show here is that when I'm talking about implementation, I'm talking about that full range, that full broad spectrum of activities. So all the way from when decision maker might be exploring and trying to figure out what's the evidence-based practice that's going to work for us. Is it a good fit? All the way through, yes, we're going to do that. We are going to develop the infrastructure that is necessary to support that. And our goal is to ultimately sustain that intervention in our community setting. So that's what I'm talking about when I'm talking about implementation, is that full broad spectrum. Which then brings me to the SIG. So the stages of implementation completion is a standardized measure that was originally created for a head-to-head trial of two different implementation approaches for implementing the exact same evidence-based practice. And that evidence-based practice was Treatment Foster Care Oregon, which was developed at Oregon Social Learning Center, where I work here. So it was an award given to Patty Chamberlain, and it was one of the first implementation trials coming out of NIH. And there was this very great approach, really fancy design to maintain randomization. But what there wasn't was a measure to be able to assess the primary outcome, which was how do we know if different agencies are following these two different implementation approaches? So I had then the opportunity to be able to observe many counties across two different states and to really understand what it was that they were doing as they were going through that implementation process. Like any good measure development, we went through multiple iterations, and we started off with 15 stages, then we went to 12, then to 10. And finally, with all of our psychometric work, we use Roche modeling, and we ended with 8 stages. And so we have these 8 stages that go from engagement, again, through competency. We currently are funded. We're working on the sustainment phase, and I'm really excited about that work. I can tell you about that at another time. But the SIG itself is a date-driven measure. So we want to know the date in which different implementation activities were completed across 3 different phases of implementation. And those phases are pre-imp, implementation, and sustainment. So this is, in the end, what those 8 stages look like. So we have 3 stages in pre-implementation: engagement, feasibility, and readiness planning. We have these 4 stages in the implementation phase. So you hire your staff and you train them, or in some cases you're reassigning or reallocating staff if you're pulling them from another existing project. Setting up your fidelity monitoring. And so oftentimes this might include having to get some new technology equipment if you're doing let's say video coaching, or you might have to make some adjustments to your EMR. Regardless, that's what happens here in getting your fidelity monitoring system set up. Then in stage 6, I refer to that as the stage of first. This is where your program launches. So this is the first client is seen, the first assessment is conducted, the first consultation was engaged in. Whatever it happens to be for this evidence-based practice to launch, that happens in stage 6. Stage 7 is sort of your ongoing monitoring. And then ultimately what we want to do is we want to achieve competency in delivering this model that we are implementing, because once we achieve competency and have demonstrated competency through all the fidelity monitoring, obviously that positions us to be able to then sustain. So this is the SIG. Throughout the SIG, you see that there are multiple individuals who might be involved at a different point in time. And really what the goal of this is to show that, just to show that this is just an example, but the goal is to show that who is involved in the implementation does change over time. And so what we're challenged with is, how do we find a measure that is able to look at this dynamic process where there are multiple individuals that are flowing in and out of the process, and where the process is very much dependent on who those individuals are being active in completing those activities at a given point in time. The different activities within, I gave some examples already, but these are just to show. So within each of the stages, there are a number of different activities that are all focused on implementation. So again, it's like you training your supervisor, your technology equipment setup, but then also in pre-implementation, and I'm going to go into great detail in that in just a second, we have things like your stakeholder meetings and your readiness planning activities, determining whether or not it's feasible and you're able to afford that activity, or afford the evidence-based practice. One thing that we've learned over the years is that when we are monitoring implementation process and we are looking at what are all of these different range of activities that might be required to implement an evidence-based practice, when we are coaching or tracking a team, one of the things that we learned is that not all missing data is created equal. So when we first started doing this, of course, there are programs, I'm sure you guys have all worked with them, where we're finding, oh, well, they skipped over the readiness process, or they were working with a funder who didn't give them the amount of time that was necessary to complete all those activities. So they just skipped right ahead, and they're serving clients a couple of weeks after being funded. So there's a very big difference between skipping over activities, and so having things truly be missing, versus maybe not doing it because you've already implemented a different yet similar enough program in your at your clinic or at your hospital setting, and so you don't want to repeat those activities. That would be a waste of resources. That would be a waste of your valuable clinic dollars. It might also be that one of those strategies was developed for an environment that is entirely different from yours, and so it's not applicable. An example of this that I like to give is an intervention that was developed and conducted in New York City, and part of what needed to happen was being able to provide a certain level of guidance, treatment intervention guidance around subway use. That's not applicable in a community environment where there is no subway. And then we also have activities where we know that they were done. We've been working with that organization. We know that they did that clinic did that, but we just don't know when it happened. But we still want to give them credit for doing that. And so we would say that if the activity was completed, but the date itself was not known. And remember, the SIG is a date-driven measure. So there are 3 scores. There's the duration score, how long does it take to do these activities? The proportion score, so what proportion of recommended activities actually are completed? And then there's the stage score, how far in this implementation process do different organizations get? We have developed over the years adaptation and or customization process. So there are 2 things about this. When I refer to adaptation, I'm referring to where we work with a group, with an evidence-based practice developer, provider, purveyor, who is wanting to implement more broadly. And we build from the ground up, we operationalize what their implementation process looks like, still within the 8 stages though. Or we might customize. If we are customizing, that means that we are using universal items. So I'm not going to go into this. I think folks have probably heard me talk about this before, but we have what's referred to as the universal SIG. The universal SIG are 46 items that are sort of common across all the different practices that we've worked with. We developed this through a reliability exercise and really found that there were these 46 activities that also through lots of testing demonstrate equal predictive ability of a full customized SIG. So again, we can either tailor or adapt a SIG from the ground up or customize these 46 items specific to a particular evidence-based practice. So we have developed a standardized way of doing this. We operationalize the process with the developer group or with the purveyor group. We come up with the decision rules around scoring. And then what we do is we plug all of this into the SIG website. So the SIG is a technological tool. It is it's web-based driven and where you do all of the data entry. And we've done over 45 adaptations or customizations now. I think we're actually over 50. And what that does is as folks are feeding their de-identified data into this SIG repository, that means that we are simultaneously growing and building a very large SIG database of all these different programs that are operating on a very similar scale. And so because the individually tailored SIGs also have those universal common items, we are able to then conduct analyses on those 46 universal activities that occur across the different 8 stages. So currently we are tracking over 1,800 sites. What I'm going to show you is I'm going to show you just some outcomes of sites where we know what the end status is. So that means that we have a bunch of sites that are still active that we are tracking worldwide across these different evidence-based practices. But what we also know is that we have complete data on teams that have gone as far as they're going to go. And so we have these 1,511 teams. Of these, we see that a huge proportion, 64%, discontinue. And of those, the majority discontinue in pre-implementation. So we see that we lose a lot in engagement, more in feasibility, and more in readiness planning. So this is a lot. Some might say, well, that's a really good thing. Folks are dropping out. They're discontinuing before they've spent too many money resources or before this service was available to clients. And so clients don't know what they're missing. And so there's some good value in dropping out that early. But the bottom line is if they engage, this means that the practices also were identified by these different organizations as being ones that were necessary and needed to treat their populations. So what this is actually showing us is that there was a need in these areas for these different evidence-based practices that were identified. And in fact, we are continuing to not be able to provide these services to these clients that are in need. However, more hopefully, of those that do complete pre-implementation, so we have 46% of that 1,500 that make it through pre-implementation. And if they make it through pre-implementation, then about 55% will launch a program, and about of those 26% will be competent. And so of this, again, now very small funnel, we've got 46% of that total 1,500. This is what we're looking at. And so what does this mean if we look at the 1,500 as the denominator? It means that we're landing at about 12% of programs that are making it to competency so that they are able to be sustained in the community. So across all of these different implementations, we just keep replicating the same outcomes. That's what folks are interested in. And so what we've found is that the SIG can reliably distinguish good from poor performers between different implementation strategies, and that pre-implementation predicts successful program startup, and that pre-implementation also predicts discontinuing programs. The combination of pre-implementation and implementation then, of course, predict the development of competency. So none of these outcomes are rocket science. None of these are things that we wouldn't necessarily guess or hypothesize based off of what we know in terms of how, I guess, few programs actually make it through to sustainment. But I'm going to focus on pre-implementation because I believe that that presents the greatest opportunity for us to be able to move the needle on successful implementations. So I'm going to take you through what, from those universal items that I was mentioning, what those pre-implementation activities are and why it is that I believe that this is where we really want to put our efforts. So they're, again, not rocket science, for very easy engagement activities around establishing engagement between the developer or purveyor group and the clinic, hospital setting, whatever, the provider that's interested in the evidence-based practice. So there's a series of engagement activities that one goes through. And what this data here shows us, so now we're a little bit lower, notice we're at 1,481. That's simply because I didn't update the analyses, and so I apologize. But what we see here, because the outcomes are consistent, they've been consistent for a really long time. And what we see is that if you conduct all those engagement activities, you still have less than a 50% chance of actually starting your program. The thing about this is that us as treatment developers, we used to think back in the day that we just had to develop the program, engage people around it, get their interest and enthusiasm around it, and then they would implement. This is letting us know that absolutely is not the case. So if they decide that it is, that they do want to do it, we need to determine, is it feasible for them to be able to do it? Again, some evidence-based practices, this is a really heavy stage, and there are lots of activities that we go through to determine feasibility. But these are those 4 core things. You need to have some planning contacts, you need to have a stakeholder meeting, you need to determine, is it feasible? And we highly recommend developing a program champion. We have lots of analyses that we've conducted in the past to show that if you do not have a program champion, that becomes really disruptive. So if you do these activities, you see that you get a much bigger bang for your buck in terms of the probability of achieving program startup. So now we're, between 80 and 90% here of a chance if you conduct those activities and you conduct them well. But then where the rubber really meets the road is here in readiness planning, so stage 3. So these are the sort of, I refer to as the nuts and bolts. So in stage 2, you might have determined through your feasibility assessment that it is feasible, but in order for it to be feasible, there are going to be some changes to your infrastructure that you're going to need to make. So readiness planning is really making those changes, getting those nuts and bolts in place, determining what are the needs of your setting to be able to pull this off, and really making sure that we have an established infrastructure to support the next stage, which is moving into implementation, where you're hiring your staff and you're starting your training. So if we do this in stage 3, we see this is where we get our biggest bang for our buck. And again, I'm not going to share the analyses with you, but we have a range of analyses that really show that stage 3 are what drive a lot of our outcomes that are showing that pre-implementation is what is most predictive of achieving sustainment. So the stage 3 readiness activities really carry a lot of weight in our long-term analyses. But then we also have the matter of, you can do all these activities, but it really does matter the pacing in which you do them. So this graph shows these are, this represents teams where all of the teams made it through pre-implementation and they all did the exact same activities in pre-implementation. So there's no variation in terms of the proportion of activities that were completed. But what we see here is that of the sites that ended up certifying or going on to be successful, they completed those activities at a faster pace than those that ended up discontinuing. And so this is where we're starting to think, well, what is it about duration and the pacing of doing these activities? One thing that we've learned, though, is that how you can be successful, how you get there in the pacing can look quite different. So this is an example of a site. Think each of these dots here is a combination of this algorithm that looks at duration and proportion. So this is basically how much have you done at this given point in time in your progression. And so the most efficient process that we have found, again, through replication, you can find your one-offs, but what we really want to find is a groundswell of where we're seeing that this is an effective and efficient pattern. What we see is that by 80%, you have to hit about 80% probability by 2 months, and that is as fast as you can go. If you go faster than that, it is too fast. And so we really need to take at least 2 months to do these activities, and then you continue on at a steady pace through to successfully starting a program. This looks quite different from this team, where they start off and they get up to 40%, and then they stall out. They're not doing any activities. So now they're a little bit older here, they're a little bit older here, they're a little bit older here, but they haven't done any activities, they haven't moved. You see that we start to then lose our effectiveness. However, you can recover. And so we've learned from our data that you can recover from these experiences, but if you do so, it means that you have to do more and you have to do it at a heftier pace. So this is another example of a team that ends up being successful. We then have the team that starts off like gangbusters and then kind of stalls out, but they have done so much so well soon that they maintain effectiveness. And then we have the team that starts off really slow, kind of dragging, but they too, if given the right rate, pace and sort of quality of activities, they too are able to achieve success. So how do we take all this and learn from it? Well, one of the things that we know is, so this is, again, now looking at 800 sites. If we look at pre-implementation and implementation proportions together and the completion of those activities, what we see is that if you do the best implementation, so now we're talking about training the best staff, hiring, making the best hires, training the best staff, getting your referrals right, having your Fidelity monitoring system in place, and you do all of those things perfectly. So you do that with 100% proportion of your implementation activities, but you do it in the absence of pre-implementation, you still end up not having a successful program. So what we've learned is that the best implementation, if we ignore pre-implementation, still unfortunately will not get us to have our youth substance use programs sustaining into the future. So I wanted to take all of these lessons learned and see, could we develop a facilitative approach? Could we actually push this low sort of implementation fidelity that we see as measured by the SIG, could we push it to getting high fidelity and ergo increase those rates of getting folks past pre-implementation and then on to basically providing services and providing them well in the communities that most need them. So to do so, I am funded by NIDA for a randomized clinical trial where we partnered with, we partnered with 3 different evidence-based practices that are all focused on delivering programs at different levels of intensity, but really focused on reduction of youth substance use and negative behavioral outcomes. All 3 of them have multiple individuals involved, so they are not individually based services. They are ones that involve multiple individuals. So I want to say families, but as we all know, it's not. It's the family to the client, whoever the family might consider. The client might consider a family. And again, these are all EBPs and are all on EBP registries. So first I needed to figure out, though, with working with these different purveyor individuals, how are we going to get them to understand the SIG in the same that we understand the SIG? And so all those outcomes that I just showed you, how are they going to be able to surmise that at the individual team level, to be able to use that information to inform how they coach or guide a team in their implementation efforts? So one of the first challenges, and I'll show you later how this has continued to be a challenge, is that within each of these purveyor organizations, there are not that many clinical consultants and coaching consultants that they have. So we can't really randomize at the coaching level, and we can't really randomize at the practice level, which means that we're randomizing at the site level. That therefore means that the purveyor groups themselves overall are exposed to the SIG and are exposed to the lessons learned from the SIG, and we ask them to only provide that information to the teams that are randomized to SIG coaching, and I'll go through that in more detail. But first things first is, how do we get this information easily accessible to them? So we had our SIG data tracking website, which was, again, an online web tool. And what we wanted to do is, how could we change the features or create some interactive features to make this, again, accessible for our purveyor groups? So first thing, we've got our resource page. And so we have explanations of what the SIG is. We have our different user guides. We have different modules, and we keep updating, right? We keep increasing features to make this more user-friendly based on the feedback that we are receiving from our purveyors. We have the data entry was already in place, and so we're just building off of that. And essentially, it's a basic accordion style data entry calendar menu, very streamlined. We've gotten feedback from many groups that it's very user friendly, easy, quick, dirty to you can just kind of get in and get out. It does become burdensome to collect this data if you do batch data entry. So the goal is that you are doing data entry prospectively as you are going along and working with teams. And if you do so, then it just takes 30 seconds to enter that date that you had. And then ultimately what happens is that you end up with a page of what we call the widget page. I will show you that in a second too. One of the things that we do is we collect demographic data on the organization so that we're able to do analyses based off of things like size, funding type, who initiated the implementation, and what service sector are they working in. And then we also created on the website, again, these sort of user tools. So one that's important is around these, how to code your missing data types, because that missing data, I did not go into due to time, but that missing data impacts the way that we score things. And so we want to make sure that we have the right missing data types so that we score each team appropriately. And when I say score, what does that mean? I'll show you. I thought it was going to be next. It must be next after that. But one thing we needed to do is keep randomization. So what we did is, we're randomizing sites. And so we then have it so that for the purveyor groups, they are only able to see information on the sites that have been assigned to the coaching condition. They have a dashboard page where they can go to their team widget. They have their call guides where we ask them to upload their information from their calls, and then they also are audio recording them for us to listen to. We connect to their portal, and so they are able to put in the URL so that from the single website, they can navigate between the SIG information and their own Fidelity monitoring that they have from their own dashboards, and then our contact logs so that we're monitoring the contacts that they have with each of the organizations. So this is what a widget page looks like. And so what you can do, again, this is just a screenshot, it's not live, but if you hover over any of these boxes, it tells you what the activity is, and it tells you the date in which it was completed. You see along the bottom line here that we have the different missing data types, a code here. And so what you see on this particular screenshot here, I can't hover, so I can't tell you what the activities are, but you see that these last four teams, for instance, all are not, oh, I know what this activity is. It's a site visit. And so in the time of COVID, we are not doing they're not doing the site visit here. And so this gives us a very quick and dirty snapshot view of, oh, wait, we're working with some teams and they aren't doing a particular activity. What's going on there? The red box lets us know that this is a team that has discontinued. If we had any teams on this page that had certified, they would be surrounded by a green box. And then we see here, off to the side, this is the feedback. And so this lets us know how long, what's the duration that a team has been active. Here in this column, this is the probability that the team, based on the activities that they have conducted and the pace in which they are conducting them, that they will either successfully start up the program, or as seen at these top ones where they already have started their program, over here, they're now on the road to competency. And so we see that these top two, for instance, right now are sitting at about 79% chance they are operating together. They're part of a shared initiative at a 79% chance of achieving competency. So if we press on this button then here with the on the feedback, it takes us to a feedback page where this is more interactive, and you are able to look and see if we do the next activity in a given period of time, what is that going to do? And here we have like little benchmarks for folks. So what is it that they're looking at? This particular example of a team that I brought up here, we can see that they spent a little bit more time in that engagement process than is typical for this particular evidence-based practice, and that they spent a little bit more time in readiness than is typical for this particular evidence-based practice. But as I showed you before on those pacing graphs, there are ways that we can recover from that. So the underlying algorithms that are feeding into this take that into account. We then have our call guides where we're collecting data, information about the calls. We're looking at what are the topics that they covered. Again, we audio record that so that we're able to listen to it for our own quality assurance. And then we're having them type up a little bit about the notes, and then letting us know, is this a topic that they plan on? Is it active still? Is it a topic that they're just now introducing? Or is it a topic that they think is completed? I should have given an example of that here. And if it's a topic that they think that's completed, then what we would want to see is we would want to see the associated date on the SIG page. And this is just, again, for the research, just for the clinical trial, a way for us to maintain quality assurance. But this isn't something that we would typically have sites do. We also have a way to be able to track turnover and when turnover happens in the implementation so that we're able to see how turnover in different roles and positions are impacting the different implementations. So bringing it to this trial then, and I realize I only have a few more minutes, about looks like 10 more minutes. I won't take that long. But one of the challenges is maintaining randomization. So how do we maintain randomization when we are working in the real world with sites that may or may not be coming in parts of teams? And so for instance, we start off by asking, is this team a single team site? If yes, then we're going to randomize as a single site. But a lot of times what we find out is no. And so then we ask, well, is it an expansion team? Is it at the same organization where they have already implemented this exact same evidence-based practice and they simply are growing those teams? That means one thing. Or is this a team from a site where the teams began before the study? Is this in a team where it's the same location as any previous study teams? Are the teams going to be coached through a process together? And are they going to go through the readiness process together? So these are all decision points that we need to determine. Do we randomize as a group, or do we randomize as a single site? So this is what our current process looks like here. And so what we see is that this is a network analysis, and we see how different sites from the different programs are interconnected with one another. So for KEEP, there's a huge statewide initiative happening. And so these teams are all part of the same state initiative. However, they are not all going through the readiness process together. So this is causing some challenges, but this is, again, sort of the network of the different places and the different programs that we are working with and how it shakes down. So currently we have 53 different sites across the different programs. MDFT has 19, TFCO has 18, and KEEP has 16. So all of the programs are continuing to bring in about the same number, a similar rate. KEEP joined us later. Our original programs were MDFT and TFCO, and KEEP was interested in this, and so they became a part of this a little bit later, but we proposed MDFT and TFCO. And then you see that we have a couple of teams from TFCO and KEEP that discontinued prior to randomization. We are randomizing in stage 2, and the reason for that is because of the nature of the engagement stage 1. That's not anything where we are able to withhold information from a particular, if they got randomized to the standard condition. So our current outcomes, though, are a little bit of a mixed bag. And part of that is what we see here is that we see that both SIG coaching and standard conditions are actually doing quite well. We have, of our total, keep in mind that of the larger SIG repository that I showed you, we look at about 64% that are discontinuing, and that 84% of those are doing those in pre-implementation. From our trial right now of just 53 sites across these 3 evidence-based practices, and it's very early on, I understand, but we're looking at 15% that have discontinued. But we're not seeing those differences between the coaching and the standard condition. And we actually kind of predicted that this was going to happen. When we originally proposed this project, we had not proposed a randomized design because we were worried about this. However, of course, we get our reviews. And so we made it a randomized design for our resubmission. But exactly what we were worried was going to happen is happening. So once you learn something, it's really hard to unlearn something. And we are getting lots of feedback from the coaches and the purveyors that they themselves, although they do not have access to the data for each of the teams, they are learning for their standard teams what to do next and kind of the pace in which to do it. So much so that one of our evidence-based practice partners just told me last week, I'm trying to choke a little bit on this news, that they have learned so much that they would like to change their approach because they would like to make the SIG coaching approach their standard approach that they use. They, of course, are willing to hold off on that a little bit because of the clinical trial, but really, for one of the other evidence-based practices, they have created a implementation manual for all of the teams that essentially follows the SIG. And so our ability, even though our best efforts to maintain randomization at the site level, like we're trying our best, we are having a really difficult time with contamination. We're hearing it in those calls. We're hearing on the standard calls that they are, again, kind of referring to and using this implementation approach. So why I say it's a mixed bag is, so in terms of our ability to look at the randomized clinical trial, we're challenged. However, the flip side is we are accomplishing exactly what we had sought out to accomplish, and that is that we are moving these programs to sustainment more quickly, and we are doing it more efficiently, and we are not having the same level of discontinuance that we were having before. So from that standpoint, I consider it a success. I don't know, NIDA might differ with me on that. You guys can tell me. So the conclusions and next steps is that the SIG itself is a measure of implementation fidelity across the full implementation process, that we have demonstrated these consistent outcomes with being able to predict implementation outcomes, that the SIG coaching strategy might be a promising approach to guiding successful implementation through the use of a site's own data. It's not collecting extra data. This is the data that we would be collecting anyway. And then randomization, of course, is a challenge. One of the things that we did propose, again, knowing that this was going to be a challenge and knowing that the randomization was going to be really difficult to keep from contamination, one of the things that we had originally proposed is that for we started off with the two, with TFCO and MDFT, but actually all three teams, we have existing data because they have been using the SIG website for years prior to this particular clinical trial. So we'll be able to look at pre-SIG coaching and post-SIG coaching for all of these teams. And our preliminary looks look really good on that. And then my final conclusion is that strong implementation fidelity can indeed, hopefully, successfully help facilitate successful implementation of evidence-based youth substance treatment programs. So that is it. Thank you very much.
Thank you, Lisa, for a terrific presentation, a tour de force. So we'd like to open it to questions, and I'll ask you the first question. Can you say a little more about the SIG coaching, what it is, how it's done?
Yeah, and so really, so I showed you some screenshots from the website. I myself meet with the purveyor, the lead purveyor member. So each of the purveyor organizations tend to have like their lead person, their primaries. They call it different things, but it's their lead person. Some people call it vice president of implementation or whatever. But that person, I meet with them. And I meet with them, go over the system, explain to them what to get out of it. And then on a every 2-week basis, we send reports to make sure that they are seeing the same information that we are seeing out of it. And then, as I mentioned, we are recording. And so then when I meet with them monthly, and I am able to go through some of those questions with them, problem solve things. But again, that's where it gets really tricky, because I can tell you, Jose, that there are so many of those times where I'm saying, but please don't share this with the control group. Please don't share this with the control group. And it's really challenging. But so it's both them getting it directly from the website, us providing it to them, but what we're providing them is what they can get out of the website themselves, but we just want to make sure they are getting it, and then talking to me.
So is the coaching primarily the getting of the information on how well they're progressing, or is there some, as we think about interventions, is there some method of intervention that you're using with them?
Yes, I see what you're saying. Sorry. So yes, so when I meet with them, and so for instance, we have helped them to develop those implementation activities, those 46 implementation activities. We have helped them develop tools for that, so cost calculator tools. We have worked with them on how to use that when they interact with the teams of the sites that they are working with. So we have provided them with resources, and we have provided them with training on how to use those resources with their teams that they're working with.
Anyone else that would like to ask a question?
Yeah, this is Lisa Marsh. I have a question. First of all, Lisa, thank you so much for that terrific presentation. It was just excellent. And as you know from our prior discussions, I just love this measure and the data you've got with it. It's such a useful tool and so widely generalizable, it seems, to a lot of different implementation contexts. I wonder, in thinking about these models, and you've presented it so beautifully, the way you think about the different stages of implementation and how to measure that. How do you think about the implementation? So when a system feels that something is no longer sustainable or should not be sustained, or you should iterate and sort of evolve it in some new direction over time, while perhaps hopefully while still trying to preserve the evidence-based nature of it. And I just wonder how you think about that and measurement of that and the context in which that might occur and maybe should occur.
Yeah, no, it's a great question. And it is something I've given a lot of thought to, but haven't had the privilege of being able to actually work on that. So I will just share my thoughts, but they are not empirically based. So I've been really curious to think about the process of when you're de-implementing something, the pacing of that. I think we've all experienced working with clinics where something gets sort of ripped out from underneath them and how disruptive that is. It's disruptive not only to the provider flow, but it's disruptive to the patients and the patient flow. And so how do we de-implement something while we're laying on the implementation of what should be happening? So how do we remove the what not to do while we are putting in the what to do? And I am curious about that. I think that what we could do, or what I've been toying with, is we would want to define what are sort of the de-implementation activities, and in so doing, figuring out sort of like, did it not get completed because it was skipped, or did it not get completed because it truly didn't need to be de-implemented? And so kind of figuring out what are the activities, and then both sides of those coins in terms of why something may or may not be done. And then, excuse me, and then how that layers onto the activities that we want them to do. So one thing that I think about, for instance, that's a little bit more clear cut would be like a stakeholder meeting, right? So we know that there, what we have is in the universal SIG is we have a couple of different points in that process where we recommend stakeholder meetings taking place. Of course, lots of people do even more stakeholder meetings than that, but at a minimum, we recommend that these stakeholder meetings take place. And so I could see having that stakeholder meeting and having for something like that, it occur on the same day, that we have a meeting where we as a group, you know, create a new charter, and we decide that the purpose of this meeting is different, and we're going to stop doing one thing and we're going to start introducing doing something. So I could see how those two activities might occur on the same day. But then I could also see where, like, you would have a readiness planning activity where you need to de-implement way far in advance, or at least maybe, you know, like a couple months in advance, and you have some cooling off period before you reintroduce a new strategy. And so those are all things that I sort of am kind of pondering and wondering about, but again, we haven't had the chance to test it. So I'd be really curious and interested in anybody else's thoughts on that.
Yeah, that's great. Thanks, Lisa. I think those are great thoughts. Thank you.
Yeah.
Lisa, as you know, we're recording this session.
Yeah.
I'm sure there will be a lot of members who couldn't attend today that be interested. I also wonder if we can share your slides, and if you have some publications that sort of give the big picture and integrate your model that we could share with our members.
Sure, absolutely. I can mail that to you. I
Yes,
know
please.
that the slides, is it okay? I'm gonna have to turn them into a PDF because those graph images are really
Sure.
big size. Yeah, okay.
That'd be
Yep,
great.
perfect. I will send that off to you later on today, no problem. And I'll get a couple articles too.
Thank you so much.
Yeah.
Any last words that you'd like to share with us?
Yeah, I would just like to say, first of all, again, thank you so much for having me. I think it's really exciting to talk to other folks that I don't talk to regularly. But one thing that I would just say, I mean, is I think you wouldn't be on the call if you don't believe in data. But one of the things that I have just been so struck by that I think is so remarkable is how much we can learn from the existing data that we are naturally doing. I think sometimes we really try to come up with these really extravagant ways of doing data collection. And when it comes to implementation is so messy already and so complicated with so many multiple layers. I think as much as we can keep it simple, the best. And from that, there's still all sorts of complexities in the multiple layers of richness that come from the data itself. So in all of you guys' clinical trials, I would just encourage you to think about, are there ways, I don't know if folks are doing hybrid trials on this call or what, but really looking at, I'm surprised sometimes, I myself, for the HEAL initiative grant that Jose was mentioning, my UG3, or UGH grant. That grant even, we proposed implementation strategies, but then when forced to sort of categorize them, we're using so many more implementation strategies than I even proposed. And so just being able to codify that and then be able to measure and assess that, we can learn so much to be able to move us forward. So that would just be it.
Thank you. I actually have one more question. When in the initial stages, when you're working with the system, so in many implementation models, there are some very specific interventions that you do at the leadership level.
That's right.
That readiness as well as the ongoing support for the intervention.
Yes.
So do you spell that out in your model?
Yes.
Exactly what kinds of activities does the implementer have to carry out with the agency or the leaders?
Yes, and so what we do is if we're doing a tailored SIG and we really have it at that very micro level, what we do is we have both purveyor and implementer activities. And so we do that so that we are able to see when implementations are starting to falter. Is it because the provider agency isn't doing something, or is it because the purveyor isn't guiding them in for instance, leadership and organizational processes that need to be conducted? So yes, we do spell that out. And in fact, we have a SIG that has been developed for LOCI, which is the organizational leadership intervention. Yeah.
That's what I was thinking about LOCI.
Oh, okay, great. Yeah, we have a LOCI SIG. Yep.
Okay. So you actually would apply the SIG implementation to an implementation model.
Yes.
As well.
Yes, we have a NIDA SIG. We have a LOCI SIG. I'm trying to think of other ones. We have wraparound. So other implementation strategies that are like what we call multi-component strategies. Yes, we have 6 for those. COAST-IS, which is for TFCBT. We have that too. So, yep.
Oh, that's terrific.
Yeah.
Thank you so much again.
Thank you, everybody.
We could listen to you for several days because there is so much that you're sharing with us and you have to share. But I really appreciate you taking time to meet with us. We know how busy you are. And everyone, please keep healthy, stay well. Thank you, Lisa, again.
Thanks, everybody.
Bye now.
Thank you. Bye-bye.